Good evening. I'm John Pandolfino. I'm the president of the ANMS, and it's my pleasure to welcome you to the ANMS Virtual Symposium, Better Together, Bridging the Divide Between Pediatrics and Adult GI Motility Disorders. Now, before we start this evening, I just want to take a few moments to acknowledge our ANMS team. Every year at DDW, we have an opportunity, and me in particular as the new president, to thank the outgoing officers and counselors. And since we don't have that opportunity this year, we just wanted to acknowledge the group tonight. First off, I want to thank Beverly Greenwood Van Meerveld for being a really amazing president over the last 2 years. She's been an excellent mentor for me as I assume this role. Beverly has really left her mark on the society, and she will continue to help build the ANMS legacy as she assumes her new role as the ANMS Institute Director. I'd also like to thank and personally thank the outgoing counselors, Dr. Miranda Van Tilburg, Bill Che, Eliane Ratcliffe, and Perna Kasha. They really had an amazing contribution to the ANMS. This team was extremely productive. They really worked hard, and the current counselors really brought the ANMS into the modernized version that it is today. I look forward to continuing working with the current counselors, Linda Nguyen, Baha Moshiree, Simon Gibbons, and Jose Garza, and our newly elected counselors, Dr. Jason Baker, Katya Kovacic, David Leventhal, Emin Quigley, Shanti Srinivasan, and Gregory Sayek, along with Fivos Kostafi, who's going to take over as the new treasurer, and Nick Fern, who is the president-elect. Once again, I'd like to thank everybody for their participation tonight and also look forward to the future with the ANMS. So without further delay, I'd like to hand this over to Dr. Ellen Stein.
Hello, everyone. It's my pleasure to welcome you tonight. We're going to be better together, bridging the divide between pediatrics and adult GI motility disorders, and we're going to focus tonight on gastroparesis. To start us off, we have Dr. Baha Moshiree, who is the Director of Motility and a Professor of Medicine at Atrium Health in Charlotte at the UNC School of Medicine Charlotte campus in North Carolina. She's also a current ANMS counselor.
So thank you everyone for allowing me the opportunity to talk to you about the updates in gastroparesis, and thanks to the organizers of this ANMS meeting, Stephanie, Lori, and then Linda Nguyen, who's done a fantastic job of setting up these virtual topics for us. So we know that patients with gastroparesis has symptoms that are common reasons for outpatient visits. These are things like abdominal pain, vomiting, nausea, decrease in appetite, bloating, and then we make diagnoses of abdominal pain and dyspepsia as physicians, and nausea, vomiting very commonly. Gastroparesis hospitalizations have been going up at a staggering rate. The hospitalizations have increased at a rate of 3.4 million per year, even in children. And symptoms that we see in gastroparesis, we know, do impair physical and mental health. This is based on an IFFGD survey of gastroparesis that was distributed to 1,423 patients who had gastroparesis, and their mean duration of disease was about 9 years. Patients stated that their most concerning symptom reported was abdominal pain, nausea, and vomiting. 60% in the survey were dissatisfied or somewhat dissatisfied with treatments. Their quality of life was negatively correlated with most of their symptoms, and there was no correlation with BMI or age. Also, we know that there's a considerable overlap between functional dyspepsia and gastroparesis, and this can make it very difficult for the clinician. We know that bothersome abdominal pain is really common in functional dyspepsia. It's a part of the diagnostic criteria. In gastroparesis, it's as common as in 90% of the patients. And so where Rome can be confusing is that we have all of these names of different syndromes that have very similar symptoms: functional dyspepsia, cyclic vomiting syndrome, cannabinoid hyperemesis syndrome, chronic nausea vomiting syndromes, and gastroparesis share symptoms, and oftentimes patients may go from one syndrome to gastroparesis and vice versa. This is an exciting slide in that it brings us clinical scientists together with our basic scientist colleagues, and how they are actually investigating the pathophysiology of gastroparesis. So we know that from the Mayo Group, Dr. Grover, there are macrophage-based immune dysregulation that's seen and has a role in development of gastroparesis. These animal models show decreases in the interstitial cells of Cajal and macrophage activation that leads to ICC loss. We know there are polymorphisms in heme oxygenase 1 genes that have been seen in diabetic gastroparesis and idiopathic gastroparesis, thanks to Simon Gibbons, also from Mayo Clinic. And then in Parkinson's disease, there's been a lot of advancement in research where they have found that stimulating the substantia nigra pars compacta increases gastric tone and motility in rats by activating dopamine 1 receptors in the dorsal vagal complex. This is by the Penn State colleagues who will be giving lectures through this virtual forum at a later time in November. And then very exciting for me, for my colleagues at University of Miami, is that in the autism spectrum disorder, Dr. Julia Dahlman and colleagues have found that in specific autosomal dominant version of this called Phelan-McDermott syndrome, that the zebrafish models of this syndrome have shown there are decreased digestive transit times in the upper gut of the mutant zebrafish, and also reductions in enterochromaffin cells. So this is the animal model of this motility from Dr. Dahlman's lab that really looks at these microspheres that are tagged here. And we have on the left side, the wild type zebrafish, and on the right side, we have the mutant, which is the SHANK3 mutation of Phelan-McDermott syndrome. And you can see that through time up to 24 hours, there is a delay in upper gut transit that we see here. And then also from Mayo Clinic, Dr. Grover has been looking at proteomics and gastroparesis, looking at quantifying proteins from human full thickness gastric biopsies. And they found 40 common proteins that are shared amongst diabetic and idiopathic gastroparesis. Many of these have to do with complement activation and prostaglandin pathways. And in the diabetic gastroparetic patients, there's associated with symptoms and gastric emptying. And then specifically, there's a properdin expression, which is a protein that's produced by macrocytes and T lymphocytes that stabilizes alternative pathways of complement C3 and C5. And this has been associated with bloating in the diabetic gastroparesis patients. So I think there's more to come in that area. And then in the area of idiopathic gastroparesis and its causes, we have found that gastric biopsies in some of our patients that were sicker and on TPN, who had gastric biopsies and who we stained along with our colleagues for enteroviruses, we found that there was some immunoperoxidase staining, and some of these patients were treated with IVIG, coenzyme Q10, and equilibrium with some improvement. Now, the Gastroparesis Consortium has been very active. They have looked at several things, including marijuana and opioid use in their population of patients. And their data has shown that marijuana use is associated with 11%. It's seen in 11% of their patients, whether they're idiopathic or diabetic, and that the most common users are young patients, current tobacco smokers, and the symptoms that they rate are upper abdominal pain, which are higher, nausea, vomiting scores are higher, and these patients, over 50% of them have been using marijuana for over 2 years. We also know that women have higher GCSI scores, but despite that, they're actually less often hospitalized. And then also importantly, in their 718 total patients, only 9% of them comprised of non-Hispanic Blacks. And these were mostly diabetic gastroparetics, and Hispanics only comprised 12%, and quality of life was similar to the white population, which makes us think that the consortium probably needs to expand to other parts of the country. Opioid use is associated also with increased GCSI scores in these patients and correlates with their severity of abdominal pain. So what's new in our diagnostics? We know that there are tests that evaluate mostly obstruction, mechanical obstruction. These are things like X-rays, upper GI series, upper endoscopy, CTs, MRIs, and endoflip, perhaps. And then there's tests that are better for evaluating motility and transit. These are things like gastric emptying scintigraphy, wireless motility capsule that we know is FDA approved for constipation and gastroparesis, GEBT, which is the kind of newer, older one on the block with spirulinemia, and this is also FDA approved. And then there's antral duodenumanometry, which is done really in research settings and at few centers. We also have tests of gastric accommodation and tone. This is the nutrient drink test, electrogastrography, which looks like gastric slow waves, and then balloon barometer, which is also done in research settings. And then there's interesting other new technologies such as SPECT and MRI and ultrasound that can also be done to evaluate gut transit. So the purpose of doing this diagnostic testing is to see if the findings will help predict outcomes with the different treatments. So when we looked at our population of 151 patients who had upper GI symptoms and had gastric emptying, scintigraphy, and wireless motility capsule at the same time, we found that in the patients who had non-delayed gastric emptying, dopamine antagonists such as metoclopramide and domperidone seemed to improve their quality of life much better than the pure prokinetics. And if they had delayed gastric emptying, their GCSI scores actually improved on the prokinetics, pure prokinetics, but not as much on the anti-dopaminergics. The pure prokinetics were things like azithromycin, erythromycin, botanical, prucalopride, and botulinum toxin. And then we have MRI manometry that's been really advanced further by the University of Nottingham group. I was given this slide courtesy of Dr. Luca Marciani. And I will show you now if I can play the video here, that shows really beautifully that MRI can be a sort of a manometry looking at transit and also is able to differentiate gas versus liquid. And you can see the rest of the intestines and the nice peristalsis that occurs in normal patients. EndoFlip has also been evaluated in patients pre and post GPOM. And this study was done at University of Michigan in 20 patients who had balloon inflations of 30, 40, and 50 mils for over a minute at each volume. They looked at the prevalence of each phasic contraction, and that was compared again before and after GPOM. All these patients were refractory to medical treatment, and they had undergone botulinum toxin injections about 1 to 3 sessions. So here we have a 3D contour of this antropyloric duodenal activity where you see no phasic activity. Here we see antegrade phasic activity, and then over here it's pretty much stationary. And what they found was that the mean distensibility improved with the 50 mils after GPOM. The maximum distensibility also improved, but the minimum distensibility at none of these volumes improved after GPOM. So what does that make for GPOM outcomes? Well, we know that there are multiple trials that have now been done. They're not multi-center, and there's really no sham trials. But when you look at GCSI scores and quality of life improvements in these small case studies, we find that these symptoms of nausea, vomiting can improve after GPOM, and it may decrease their healthcare resource use and also decrease hospitalizations with this procedure. Of course, this is yet to be determined whether in randomized controlled trials this will also pan out. So how about new and old therapies? We have these therapeutic options currently. We have diets of small, frequent, low fiber, low residue diet. We have medications including prokinetics. We can do PEG-J tubes, gastric stimulation, GPOM, and then behavioral therapies for these patients, especially if pain is a huge component of what their symptoms are. So as far as treatments, the pure prokinetics and antiemetics have been listed here, and as far as where their mechanism of action is. So dopamine, domperidone, metoclopramide work on their dopamine antagonist, D2 receptor antagonist, but have other properties as well. Then we have pyridostigmine and botanical, which are working on the cholinesterase mechanism and receptors. Ghrelin agonists work on the ghrelin receptors on enterocytes, and then the traditional motility agonist, erythromycin and azithromycin. And then we have the 5-HT4 agonists, such as prucalopride and tegaserod, and others that are also called pure prokinetics. So in this study, Dr. Lee from University of Michigan looked at, in patients with upper GI symptom, the prevalence of other regional and generalized dysmotilities, including small bowel and colonic dysmotility, finding that there is delayed transit in the colon and small bowel in some of these patients with upper GI symptoms. But interestingly, in at least the 15 patients that we studied with the wireless motility capsule, we found that if the patients had delayed colonic transit on wireless motility capsule, that the gastroparesis low fiber, low residue diet did not worsen their symptoms, and their constipation did not worsen. Prucalopride and gastroparesis has been studied in this one trial. It's a randomized controlled trial of 34 patients who had mostly idiopathic gastroparesis. And this was at a dose of 2 milligrams once a day versus placebo for 4 weeks There were some SAEs, and to note that symptoms of, bloating, nausea, vomiting, and fullness satiety did improve, but this is only FDA approved for chronic idiopathic constipation. Dr. Camilleri has done a randomized placebo-controlled trial on the ghrelin agonist, which is relomorelin in diabetics, and they looked at the composite scores, which improved, looking at 4 symptoms of nausea, postprandial pain, bloating, and abdominal pain. And here we see statistically significant improvement in postprandial fullness and abdominal pain. Dr. Abel has looked at the gastric electrical stimulators in gastroparesis several times, but these are results from the National Gastroparesis Registry. And about 80 or more patients had the gastric stimulation here, and over 200 that did not. And they were compared in terms of their GCSI scores. The patients that get the gastric electrical stimulation tend to have higher scores on their GCSI scores. They have worse gastric emptying scintigraphies. And they also showed that in both gastroparesis that are due to diabetes and the idiopathic group, there is a dramatic response in terms of decrease of the GCSI scores as compared to the patients that didn't get the stimulator. So again, another proof that these can be effective therapies. And then Dr. Linda Nguyen has looked at vagal stimulation in idiopathic gastroparesis. And this is the first of these studies that looked at self-administered gamma core vagal nerve stimulator in 15 participants that used this for about 4 weeks. This was a bilateral transcutaneous cervical non-invasive stimulator that was used twice a day for prophylaxis, and then not during the flares though. And then they were given 4 stimulations. Their primary endpoint was reduction of the GCSI daily diary of 0.75 after the stimulations, and 40% of these patients met the endpoint. The reduction in gastric emptying was seen, but not statistically significant. And there was definite improvements in fullness and early satiety. So this is a promising result for this type of therapy. And then from Dr. Kuo's lab, we have the differences in terms of treatments for gastroparesis and functional dyspepsia. There's definite similarities between the two. I will point out that seeking out complementary and alternative methods would probably be fine in both functional dyspepsia and gastroparesis, as oftentimes gastroparesis can behave more like functional dyspepsia and vice versa. So in terms of how I think of the treatment pattern and diagnosis and which diagnostic study I will use in my practice, I try to determine based on a thorough history and physical, which I can't emphasize enough, whether I think the patient, for example, based on symptoms of epigastric pain, postprandial abdominal pain, early satiety, may have this decreased driving force. They may have decreased or increased slow waves, which we see in functional dyspepsia, or an impaired gastric accommodation, which can occur in functional dyspepsia and gastroparesis. If I think that, then I do, my diagnostic testing will be the nutrient drink test, which is used mostly in research settings. If I had EGG, I would explore that. And then hopefully in the future, MRI and PET. And then my treatment would be targeted at using dietary management along with neuromodulators, and perhaps vagal stimulation and gastric stimulators would be of benefit in these patients. In the patients that I think may be pylorus spasms, whether it's diabetes or post-surgical or some abnormal compliance at the level of the pylorus, I may think of looking at wireless motility capsule, or perhaps even now EndoFlip, and then assessing the response to pyloric toxin injection, 200 international units prior to thinking about GPOM or pyloroplasty. And then in those with antral hypomotility, which are the traditional patients that we think of as gastroparesis, those have connective tissue diseases, for example, that have some kind of extrinsic innervation, enteric nervous system damage, for example, in our diabetics, or dysautonomia. I think of the traditional gastric emptying scintigraphy, GBT, wireless motility capsule, and in a few patients who are malnourished, antroduodenal manometry. And then again, we manage them with diet, pure prokinetics, and antiemetics. Sometimes we'll think about gastric stimulators. It sounds like the more severe patients will respond in terms of their nausea, vomiting especially, and then possibly vagal stimulation. And in those that are very ill and losing weight and malnourished, a PEG-GJ would be considered. So finally, this is gastroparesis month right now, and the ACG's gastroparesis guideline will be upcoming. And thank you so much for allowing me to present to you.
Thank you, Dr. Moshiree. So it'll just be a few moments as we switch slides, and we now will have the pleasure of hearing from Dr. Carlo Di Lorenzo. Dr. Di Lorenzo is the Chief of the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Nationwide Children's Hospital. He is a professor of pediatrics at the Ohio State University College of Medicine. He's been awarded the Master Award in Gastroenterology by the AGA Institute and has been a president of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and he also chaired 2 Rome Criteria committees and has been an ANMS counselor secretary. And he will present tonight, Gastroparesis, Our Kids, Just Little Adults. And can you put on your video, Dr. Di Lorenzo?
Can you hear me now?
Yes.
Okay. So good afternoon and good evening, everybody. Thank you, Ellen, for the very kind introduction. And thank you to the ANMS, actually, for including pediatrics in this series of webcasts. The reason for including pediatrics is that GI diseases are not always the same in pediatrics as they are in adults. For example, let's take a hypothetical 8-year-old boy with a GI disease. There are conditions that are very similar between children and adults. For example, presentation, diagnosis, and treatment of IBD, GERD, IBS, or eosinophilic esophagitis are very similar between children and adults. On the other hand, there are a variety of other conditions, many of them that fit within the umbrella of functional or motility disorders, such as functional constipation or pseudo-obstruction, that are quite different. And one of the most different one is gastroparesis, hence the need for this presentation. And in fact, I'm gonna go as far as giving the take-home message at the beginning, rather than at the very end of the presentation. And the take-home message is that children with gastroparesis do differ from adults with gastroparesis. And I'm gonna take the next 12, 13 minutes to try to make the case why this is true. Let's start with one of the largest case series that has been published, 239 patients. Actually, you can recognize a couple of illustrious adult gastroenterologists among the co-authors of this pediatric case series. And in this case series, you can see the majority of children with gastroparesis had idiopathic forms. But the diabetic ones that are a sizable subgroup in adults with gastroparesis were all very rare, only 4% in that case series. Interestingly, psychiatric comorbidities were quite frequent. In this case, almost 30%. And my guess is that actually that underestimates the psychiatric comorbidity that many of the children with gastroparesis have. And I often tell my fellows and the patients, it's almost never just about the stomach. And certainly it's almost never just about the gastric emptying. Now, another big difference between children and adults is that the outcome. In this fairly large case series, 60% of the children improved within 24 months. And that was confirmed by another large case series, another 230 children. This was a study done in Boston. They are authors looking at the etiology of the gastroparesis in the patients, found that post-viral forms were actually quite common, close to 20%. And once again, outcome was good, 61% symptom resolution at 36 months. And interestingly, they found that the post-viral forms were those that actually had the best outcome, were those that eventually resolved with time and with treatment. Another interesting observation that they had is that a subgroup of their patients were found to have a mitochondrial disease. So think about that in some of your patients, especially those that tend to have a more generalized forms of motility disturbance. In fact, patients with mitochondrial disorders have often both gastric emptying delay, but also generalized dysmotility, as you can see in this study from Mark Rhodes and colleagues, about half of the patients that had mitochondrial disorders had also prolonged intestinal transit times besides having delayed gastric emptying. So how do we make a diagnosis? In children, much like in adults, there is often a lack of agreement between, a disconnect between symptoms and the objective delay in gastric emptying. In fact, sometimes the gastric emptying improves, but the symptoms persist, which often confuses referring physicians and families and the patients themselves. So even if the symptoms are not always predictive of gastric emptying findings, at the end of the day, symptoms are still important. And I would like to make almost like a dogma that if your patients vomit within seconds or minutes from eating, the diagnosis is not gastroparesis. It's amazing how many patients I get referred that eat and then vomit within seconds. Usually those patients have rumination syndrome. They do not have gastroparesis. In gastroparesis, the food doesn't bounce off the stomach as soon as it's ingested. It usually stays in the stomach for hours and then eventually either slowly empties or is vomited after several hours. So remember, symptoms are still, history is still important. So let's do some tests. What are the tests that are available for the diagnosis of gastric emptying, and what are those that have been particularly found to be helpful in children? First, there are some tests that are not particularly helpful, and as much as I love to do manometry tests, I need to acknowledge that for a diagnosis of isolated gastroparesis, intraduodenal manometry is not a great test. It's a much better test to investigate the generalized motor function of the upper GI tract. I will not trust my intraduodenal manometry just to tell me that somebody has isolated gastroparesis. What about upper GI endoscopy? Upper GI endoscopy is not particularly helpful in patients with gastroparesis. In fact, in this study published by the group of Bruno Ciampitazzi and colleagues in Houston, they found that if you compare patients with normal emptying to patients with gastroparesis, you are much more likely to find a mucosal abnormality or an endoscopic abnormality in the patients with normal emptying. Patients with gastroparesis usually have a normal gastric mucosa and normal endoscopic appearance. In fact, the most important information sometimes for an upper endoscopy is finding food left in the stomach despite the MPO status. So in children, much like in adults, nuclear medicine is considered the gold standard for diagnosis of gastroparesis. But we have two big problems in children. One is the duration of the test. How long do you investigate? And the other one is what kind of meal do you use? Because in pediatrics, we study children from 1 year of age to 18 years of age. And also we struggle in having normal values in children. So we end up still using the same normal value and the same test that Tom Abel and colleagues have published several years ago as the value that are found in normal volunteers, even though those are adult values, not pediatric values. So we try to suggest that 4 hours emptying of less than 10% or more than 10% left in the stomach after 4 hours is diagnostic of gastroparesis, and we use a meal that approximates as much as possible the one used by adult colleagues. It's a problem because Miguel Saps and Ashik Ogley, when they were still in Chicago, found that only 5 out of 20 pediatric centers at the time they were using a 4-hour test. Still, many were using a few years ago a 2-hour test. And they found that there were patients, about 23%, that had a normal 2-hour test, but an abnormal 4-hour test. So they concluded that extending the test to 4 hours had an considerable increase in the diagnosis of gastroparesis. The other problem, as I said, is what is a normal value? How well do normal children empty? The only study that I found that was published by using a radiolabeled radioactive meal in normal children of different age comes from India. Unfortunately, the meal that they elected to use was probably a culturally sensitive, culturally appropriate meal for that population, but one that is probably not likely to be generalizable in many other countries. They use rice, black gram. I'm not sure I ever had black gram in my life, cooking oil, and they studied the children in a supine position. They kept them supine for 4 hours. And they found that the upper limit of normal was 22% left in the stomach after 4 hours. So a much higher threshold for a diagnosis of gastroparesis that we usually use. So this is still a big struggle. Another important study, again, from Chumpitazzi and colleagues, found actually that children of different ages and different size and different BMI have different speed of gastric emptying. And so I was actually referred a toddler last week, a 2-year-old that had a solid gastric emptying with scrambled eggs and toast and had a delay in gastric emptying. I have to be honest, I don't know what a 2-year-old normal gastric emptying is when given scrambled eggs and a toast. So we still probably be stuck with using the adult value and looking really for extreme. Somebody empties only 40% of 4 hours, obviously has delayed gastric emptying. So we need other tests. We need ideally less invasive tests that can be used by children of every age. The wireless motility capsule is very attractive for children. No radioactivity, no X-ray, no invasiveness. The problem is the size. It can be swallowed only by children older than 6 or 7 years old. We did a study in which we compared the wireless capsule to a gastric emptying and to longitudinal manometry. We found actually the wireless capsule correlates well with a gastric emptying measured by scintigraphy. Doesn't quite give the same information as longitudinal manometry, but it's a good substitute for, at least in our patients, for a scintigraphic study. There are now breath tests that Baha has mentioned in her presentation that are available. They all use the same principle of measuring C13, which is not radioactive, in the breath. You can collect breath samples at different time intervals. After ingesting a meal, you can use different type of meals. You can repeat this test several times. And the rate limiting factor for the excretion of C13 in the breath is the gastric emptying. So delayed gastric emptying, delayed appearance of C13 in the breath. And people have used octanoic acid and found in Europe a perfect correlation, almost perfect correlation with a gastric emptying measured by scintigraphy. We now have an FDA-approved breath test by using spirulina, and we actually did a study that has been submitted for publication in which we correlated C13 with a scintigraphic test. Once again, non-invasive, very well accepted and tolerated by children. Unfortunately, the correlation in our study was not perfect. So they probably don't quite measure the same thing. There was also a different lag time in the spirulinum breath test compared to scintigraphy. Finally, treatments. I said the prognosis, the outcome is better, and treatment for gastroparesis work better in children. I probably believe that that's the case because those are not end organ dysfunction. Our children are not as sick as many of the adults with gastroparesis. Erythromycin, this is a review paper that summarized the literature a few years ago, and in infants and neonates, erythromycin was shown to improve tolerance to feedings, to oral feedings, so to G-tube feedings, in almost every study. You have to remember that there is a risk, if given to neonates, to cause hypertrophic pyloric stenosis. There was also a study in which domperidone was actually compared to cisapride in patients with diabetic gastroparesis. I don't know how they found so many children with diabetic gastroparesis in this study in Naples and Rome in Italy, but they found that domperidone worked better than cisapride. Domperidone, of course, had the same issues in pediatrics as it has in adults of how to easily access it. You need an IND, and many of our motility centers do have it. Finally, non-medical intervention. Botox is very easy to administer. We use between 100 and 200 units divided in 4 quadrants, injected in the pylorus. And what we found is and the group in Boston published as well, is that it does actually help. In this case series, Botox helped vomiting, abdominal distension, nausea, feeding intolerance in patients with gastroparesis. And interestingly, the effect lasted actually quite long, up to 8-10 months, maybe because of the more favorable natural history of the condition. Finally, the last topic I want to discuss is the so-called holy grail of gastroparesis treatment, the gastric electrical stimulation. We have now implanted gastric pacers in close to 100 children of different ages, as young as 2 years of age. We often, in our center, do a temporary stimulation by attaching a wire to the mucosal side of the stomach with few clips and having an external gastric pacer. And if the patient feels well and has improvement in symptoms, we proceed with a more permanent implantation of the pacer. And these are a couple of the studies that we published with Steve Teich, our surgeon, when he was still in Columbus. And we can, in summary of these two studies, almost every symptom improved. Nausea especially was very responsive to pacing, fullness, early satiety, bloating, and so on. And more interestingly, actually the mode of feeding changed as well. Patients were able to go from G-tube to oral feeding, from J-feeds to G-tube or oral feedings, and even able to discontinue TPN. So in summary, post-viral forms carry the best prognosis, at least in children. There are multiple tests you can use to diagnose gastroparesis, but nuclear medicine is still the gold standard, although it has some limitation. And there are many medical and non-medical interventions that has the potential to help children with gastroparesis. So I hope that I made the case that once again, children with gastroparesis are not just little adults. Thank you for your attention. I'm looking forward to the Q&A session.
Thank you, Dr. Di Lorenzo. There's already questions hopping in the Q&A portion, so if you have more questions, please get them out there. I'm very pleased and honored to present our next speaker, Dr. Linda Nguyen. Dr. Nguyen is a clinical associate professor of medicine. She serves as the clinical director at the Stanford Digestive Health Center, and she's been the director of GI motility and neurogastroenterology since 2008 at Stanford University in California. She is also a counselor in the ANMS. She will present for us tonight gastroparesis and its associated conditions.
Thank you, Dr. Stein. So today I'll be talking about gastroparesis and associated conditions. Oops. Let's see here. My goal is to highlight different conditions that may impact our patients with gastroparesis. This is not meant to be an exhaustive or all-inclusive list, nor a detailed discussion of each of these conditions. You may find that there's a common theme there, that some of these patients are younger than those without the associated conditions. So why is this important? Because I personally think that we are missing the mark in caring for patients with gastroparesis. As both Drs. Moshiree and Di Lorenzo have pointed out, that treatments for gastroparesis right now are dietary modifications, acid suppression, antiemetics, pain control, and pro-motility agents. And despite the ongoing research and the updates that were discussed by Dr. Moshiree, metoclopramide is really the only FDA-approved therapy we have at this time. So it's not surprising that over the prior decade that we see an alarming trend of an increase in opiates and a decrease in prokinetics in patients with gastroparesis. And Dr. Moshiree discussed this earlier, so I'm not going to touch on this too much, but there may be presence of extra gastric dysmotility in our patients with gastroparesis that may be contributing to the lack of effective therapies. The gastroparesis symptoms are nonspecific, and could they be attributed to small bowel or colonic dysmotility? What about somatic pain conditions in patients with gastroparesis? And these are two separate studies utilizing the NIH Gastroparesis Consortium. And if you look on the right, in patients with, gastroparesis, compared to the general population, those with gastroparesis are more likely to have migraines, endometriosis, fibromyalgia, chronic fatigue, and interstitial cystitis. In looking at patients with idiopathic gastroparesis, concentrating on abdominal pain, those with severe abdominal pain were more likely to have migraines and a prior cholecystectomy compared to those with more mild to moderate symptoms. So this got us interested in looking at overlapping pain. And this study was done in collaboration with our Stanford Pain Clinic and was presented at ACG last year. Using a body map, we looked at the distribution of pain, and we characterized patients by localized, intermediate, or widespread pain. And widespread pain was defined as abdominal pain plus 4 or more areas of pain. And what we found was that widespread pain was associated with greater severity of GI symptoms, greater pain interference, anxiety, depression, and anger. We did not find that widespread pain was associated with adverse childhood experiences. However, trauma is associated with alterations in GI physiology, symptoms, and disability. In the study utilizing the gastric barostat as well as gastric emptying, prior history of sexual abuse was associated with lower sensory thresholds or visceral hypersensitivity, while physical abuse was associated with a higher sensory threshold and faster gastric emptying. And in a study looking at central sensitization or summation of pain in patients with functional GI disorders compared to controls, those with functional GI disorders in a prior history of trauma had greater summation of pain. So with each application of heat, there was an increased severity of pain that was experienced compared to patients with functional GI disorders without trauma and healthy controls. So they found that trauma was associated with greater symptom severity, presence of non-GI chronic pain, as well as increased disability. What about disordered sleep and chronic pain? And this was a study done, published by Dr. Jennifer Ha here in our Stanford Pain Clinic, and she looked at the impact of disordered sleep on opiate use or opiate misuse in patients with various chronic pain conditions. And she found that those with sleep disturbances were more likely to have or experience opiate misuse. What's interesting is that they found that for every 1 hour increase in the average nightly sleep, it decreased the odds of opioid misuse by 20%. So just kind of let that sink there, that sleeping an extra hour a night decreased the odds of opioid misuse. What about opiates and GI physiology? In patients with gastroparesis, almost 70% of patients experience sleep disturbances, most commonly unrefreshed or fragmented sleep. And those with disordered sleep tend to have more severe symptoms. And we've seen this in terms of opiates impacting GI physiology in the esophagus, slowing stomach emptying, impacting secretions, colonic contractions. And why is that? Well, disordered sleep or insomnia is associated with increased sympathetic activity. And what does sympathetic activity, increased sympathetic activity do? It results in decreased parasympathetic activity, which can be associated with heightened gut sensation, altered motility, increased inflammation, which further impacts sleep. And then you get into this vicious cycle. So I touched a little bit on the autonomic nervous system. Briefly, the autonomic nervous system comprises of 2 branches. You have the sympathetic and the parasympathetic. The sympathetic is your fight or flight, like you're being chased by a dog or a bear. The parasympathetic nervous system is the rest and digest. And as you can see on the diagram to the right, the autonomic nervous system innervates the viscera. So it's not surprising, so that with increased sympathetic activity, you have increased cortisol. You can see mast cell activation, release of neurotransmitters, inflammatory cytokines, and changes in the microbiome. And again, the altered motility that I discussed earlier. So it's not surprising that autonomic abnormalities have been described in gastroparesis, functional dyspepsia, cyclic vomiting syndrome, and IBS. As you see on the right, the autonomic nervous system has significant innervation of the GI tract. And again, not surprising with this innervation that up to 80% of patients with dysautonomia experience GI symptoms, with nausea and vomiting frequently the most common symptom. And when you look at the motility, rapid emptying is actually more common than delayed gastric emptying. So this is a study we conducted with the Gastroparesis Consortium using heart rate variability as a measure of autonomic activity. And we looked at gastroparesis symptoms as well as gastric emptying scintigraphy. And what we found was that delayed gastric emptying was associated with a low resting sympathetic activity and parasympathetic excess during Valsalva or standing challenge. When you look at symptoms, those with mild to moderate gastroparesis symptoms had sympathetic hypofunction, but then those with more severe gastroparesis symptoms had parasympathetic hypofunction. Switching gears a little bit, I'll take us back to autonomic dysfunction afterwards. In terms of Ehlers-Danlos syndrome or hypermobile EDS, it's a heritable connective tissue disorder that's not uncommon. There is a female predominance, although it is genetic. There's not yet an identified gene for hypermobile EDS, which is the most common form. The features are the joint hypermobility, skin changes, but also systemic manifestations. I'm not going to go into this in detail, but just so you know that HEDS was reclassified in 2017, but the majority of the studies that are presented or that we've looked at really use the 1998 Beighton HEDS criteria, which I'm not going to read through here, but you can see on the right that there are maneuvers that you can ask patients to do. It takes less than a minute or two to do in the office. What are the clinical manifestations of EDS? And as I said, due to the changes in the diagnostic criteria, for the purpose of this talk, I'm going to lump HEDS and HSD together. And you can see by this diagram that there are multiple organ systems that are affected in patients with EDS or HSD, with GI manifestations really involving the entire GI tract, musculoskeletal symptoms, as well as CNS symptoms. So in patients with a known diagnosis of EDS, up to 80% of, or up to 87% of patients will experience GI symptoms, which I described earlier. But in a study where they went into a secondary GI clinic and tried to evaluate patients for EDS, they found that a third of patients presenting to this clinic met criteria for EDS, and they were diagnosed with EDS for the first time. Those who were already diagnosed with EDS and were known to have this diagnosis prior to coming into the GI clinic, they did have more severe GI symptoms and were more likely to be diagnosed with functional GI disorders. But overall, patients with EDS and functional GI symptoms tended to be younger, female, more likely to have fibromyalgia, chronic pain, higher autonomic scores, and decreased quality of life. So what are some of the autonomic and motility abnormalities that we see in EDS? So this is a study out of the Mayo looking at autonomic function in patients with EDS. About 50% had some type of autonomic function testing abnormality, with POTS and small fiber neuropathy being the two more common ones. In looking at scintigraphy, over 20% had abnormal gastric emptying. Here they found that there was essentially equivalent in terms of rapid and delayed emptying, and almost 30% had abnormal colonic transit, with majority of patients having delayed emptying, and 60% having pelvic dysinergia. So what about POTS? mentioned POTS earlier with EDS. What is the features of POTS? It's an exaggerated heart rate response with standing. Typically, patients will complain of dizziness and palpitations, but related to the GI world, they may also complain of increased nausea and vomiting. You can diagnose this in your office by having patients stand and look for a sustained heart rate increase of greater than 30 beats per minute, or a heart rate of greater than 120 beats per minute within 10 minutes of standing. And their sort of POTS can be categorized into three types. There's the hyperadrenergic POTS, has to do with increased sympathetic activity. The hypovolemic POTS, that has to do with decreased venous return, and neurogenic POTS with impaired vasoconstriction. As with most things, there is frequently overlap there. So what are some of the gastrointestinal manifestations of POTS? Again, nausea, vomiting, and abdominal pain are the most common presenting symptoms. If patients have POTS and small fiber neuropathy, they were more likely to have GI symptoms, and the symptoms tend to be more severe. So how do I approach patients with gastroparesis? So I frequently screen for extragastric GI symptoms such as constipation, dysphagia, dysnergic defecation, and evaluate accordingly. I assess for comorbid conditions like sleep, migraines, fibromyalgia, fatigue, psychiatric conditions like anxiety, depression, PTSD, and I didn't talk about ARFID, but patients with gastroparesis or any GI disorder really can have acquired eating disorder due to the symptoms. I do evaluate patients for possible EDS or POTS, especially in those with multiple overlapping conditions. And when I choose therapies, I try to choose those that can help both the GI symptoms and the extra GI symptoms. For example, if they have POTS and gastroparesis, I may use pyridostigmine, which can help with POTS as well as GI motility. So hopefully with my whirlwind tour through other conditions associated with gastroparesis, I'm able to encourage you to challenge Occam's razor, or perhaps consider Occam may have been right, but we don't yet quite understand the underlying pathophysiology that connects all of these conditions. And thank you for your time. And
Thank you, Dr. Nguyen. So I'm going to ask all of our panelists to turn on their video and their sound and join us here. And we have a little bit of time left in the hour to go over some of the questions. I know that we've answered 12 so far, and the answers were fascinating. And we may not finish everything today, but we will follow on Doc Matters when we're done, and we'll keep discussing all the great questions from today. I think there's a theme of questions, and I know that Dr. Moshiree has some guidance for us. Given the significant variability in gastric emptying test results, as was shown by Baruka, how do you interpret a normal test in a patient who's got the cardinal symptoms of gastroparesis?
I think that's a great question. We know that there's data where the same patient who has complete symptoms of gastroparesis over time and has multiple gastric emptying studies can have different results. And so I would really go with the patient's symptoms. And if they have predominant symptoms of nausea, vomiting, and it's not one of the Rome 4 criteria that meets the criteria for cyclic vomiting syndrome and the other chronic nausea syndromes, then I would just basically treat them with prokinetics regardless. And so it doesn't really change my management. The small frequent meal, low fiber diet, I recommend to both my functional dyspeptics and my gastroparesis. So I feel like it doesn't really change my therapy if it is normal and patient has classic symptoms. Now, if the symptoms are more satiety and abdominal pain, then I focus on neuromodulators, and I think of that patient as more of a functional dyspeptic.
And can I take a vote, Dr. Nguyen, Dr. Di Lorenzo, and Dr. Moshiree? If the gastric emptying test is not done yet and you saw food on the endoscopy, You're looking at it, it's been 8 hours. They say it's been 12, 16 hours. Are you convinced based on that endoscopy that they have gastroparesis based on that finding?
I'm going to take this first. And never completely trust the child that they are NPO. Also anxiety does delay gastric emptying. If you're really nervous and you've really been anxious and the kid doesn't know where he's going. And but I would not make the diagnosis just based on finding some food. I think the setup of an endoscopy, going to the hospital is not quite normal life environment. But it is one factor. I would probably do a scintigraphic study after that.
I think for me, it depends. So it depends on if the patient has other systemic disease. So if they have, for example, cystic fibrosis or Parkinson's, I'm going to assume that the patient has gastroparesis, although I may need a gastric emptying study in order to be able to give them certain prokinetics or put them on trials. But in general, if I see food in the stomach, I assume that perhaps it was a high-fat diet that the patient ingested, and that could be the reason for the abnormality. So I do repeat a gastric emptying study.
Yeah, so I do a gastric emptying study, but it really depends on what is in the stomach, because the scintigraphy is really a low residue meal. So if you have, lots of fiber, it may be a migrating motor complex problem that you're not picking up with scintigraphy, or as we looked at earlier, is that you may be dealing with, extra gastric dysmotility with the small bowel or even colon, or sometimes with the esophagus patients, they may have an esophageal dysmotility that the food was in the esophagus, and then when you do the endoscopy and the sedation, it moves into the stomach.
Okay.
Also ask them what they ate last. They know that they're not going to eat the morning after. They load up on very fatty meal. They're going to eat like double. So everything needs to be taken into account.
Now, there was another question, and I admit we don't do this at Hopkins right now outside of research, but is anyone using a nutrient drink test?
I do that test in my population of patients that cannot afford to have a lot of these tests that are very expensive. But I also think it's actually helpful in the functional dyspeptics, and it gives me a rating system on how much they can actually drink. Because if I'm going to put them on some protein shake or supplement, then at least I know how much they can tolerate. So it's like, I call it the poor man's test, and it can be done in the office. So I probably do that 2 or 3 times a month. But I do find it useful. I know it's mostly done in research.
Yeah, we don't do it, mostly research.
Yeah, research.
And then you talked about the data, Dr. Di Lorenzo, of possibly using smart pill to assess patients. Is that a common practice, and when do you kind of bring it in?
The limiting factor is unfortunately insurance coverage. We often bring it up. There are some people willing to pay out of pocket. It's rarely covered by insurance in pediatrics, but people love the idea of having a little capsule that they swallow. It's a good sized capsule. It's like the endoscopy capsule. So you're not going to be able to give it to a 2-year-old, but 8, 9-year-old and older, they can do it.
Anybody else, any of the adult doctors who are using the smart pill in practice?
Yes, so we use it, and similarly to Dr. Di Lorenzo and the pediatrics, the insurance is the limiting fact. If patients have constipation, bloating, sort of lower symptoms, then I'll typically choose the wireless capsule motility because I'm concerned about the extra gastric dysmotility.
There are a series of questions about the vagal nerve stimulators and the gastric stimulators. Dr. Nguyen, outside of a research study, are there any vagal external stimulators in use?
Right now, they are research only for GI conditions. The handheld cervical vagal nerve stimulator is FDA approved for migraines and cluster headaches. So the device is available, but insurances will not cover it for gastroparesis or pain. But if you're able and willing to pay out of pocket, then yes, it is available.
It's great that Linda was presenting the extra GI manifestations of gastroparesis, and oftentimes our patients have migraine headaches. So I have been using that as my reason for placing them, like, or having, sending them to a neurologist who then has them place it. And I have found that it has been effective for their upper GI symptoms as well. But again, that's for the headache, the migraine headache, and not for gastroparesis.
So I think we've got time for one last voting question. Do you all get a series of autonomic function studies in all patients, or do you pick particular patients that you get them in?
For me, not in all patients. Only patients who have classic POTS-like symptoms. It's very hard to find a lab that does it well, that likes to do it. I select very carefully the patients to test. You don't want to add diagnosis after diagnosis. They all come now with a triad of POTS, Ehlers-Danlos, mast cells activation syndrome, pseudo-obstruction, gastroparesis. Got too much going on. I try to simplify.
So we're fortunate in that we have a robust autonomic neurology group here at Stanford. I don't refer all of my patients, but I do screen for autonomic symptoms. So they have POTS, kind of symptoms of small fiber neuropathy, positional symptoms, but urinary as well as cardiac. Then I'll refer for testing.
Yeah, I usually send mine to one of our cardiologists who does the workup. But again, I self-select the patients that I think need further testing and would benefit from therapy.
Well, I think our time is just about up today, but thank you everyone. And if you follow us on Doc Matters, we'll keep going through the questions and answers there and keep the discussion going. And thank you everyone for joining us tonight.